Hey folks, Ross here from OpenAirway. The next device I want to talk about is the TotalTrack VLM. VLM stands for Video Laryngeal Mask, and this is really a hybrid between a video laryngoscope and an intubating laryngeal mask. Now this is not a brand new concept. There was historically a device called the Tract, which is made by the LMA company, but that doesn't seem to be commonly available on the market any longer. So really this is the only device in its class at the moment. It consists of two main parts. There's the disposables, which you get in a blister pack, and there is a reusable camera head which you keep in a nice little box like this. Now the camera head has got a display screen with recording capabilities, a memory card, and then a camera on a stalk. This is a chip-in-tip CMOS camera, and that fits inside the disposable when it's in use. So let's hang on to that for a moment. Inside the blister pack you get basically everything that you need for the patient except an endotracheal tube. So there's some instructions if you want to read them. You get quite a nice bougie, which I'll show you how that fits in later. You've got a syringe to inflate your cup. You've got some lubricant. I'm going to substitute that for some mannequin lube in this instance. And you've got an elbow connector. That use will become clear in a moment. And then you've got the actual laryngeal mask itself, which comes basically in two sections. So there is the LMA portion, which you can see has got a drainage tube on the end there, which comes out over here. So this is for gastric drainage. So this would fit in as a second generation supraglottic device. It's also got this blue portion, which is a removable plastic sniffer. And if you look at the profile of that, you begin to see how this would fit with the heritage of something like the AirTrack, in that it's almost like a channeled video laryngoscope. And this device is designed by Dr. Pedro Acha, who's the man behind the AirTrack. So you can see how the history in these things fit together. Now inside this disposable are the batteries that power the camera, so you never have to worry about charging up your camera. But of course when you are throwing this away, you should give consideration to the correct disposal of the batteries according to what happens in your center. And what you see is missing here is any kind of stem to connect my laryngeal mask to my ventilation. And that is because the one thing that's not in the blister pack is an appropriately sized endotracheal tube for your patient. You've got to select that based on the patient that's in front of you. When you want to use this device, you take it out of its packaging, you check and lubricate your endotracheal tube, and then you load the endotracheal tube into the side channel here. I like to give it a twist to make sure the lubricant is smoothly spread. And the cuff of the endotracheal tube sits just inside here. And where it's inflated, it occludes this channel, and the endotracheal tube becomes the stem. There's some depth markings here, which allow me to get the distance right there, and then I can blow up my endotracheal tube cuff, and right. Now, my endotracheal tube is fixed, and it's functioning as the stem of the laryngeal mask. Other things for preparation, well obviously I'm going to make sure this cuff is mostly deflated. I'm going to lubricate the back of the device like I normally would, and a little bit on the sides, taking care not to get any in the bowl over there. And then I like to pre-place this elbow connector on the ET tube. The reason for that will become apparent just now. Right, so now we're nearly good to go. We need to load the camera so we can see. Now, the camera stalk fits down a channel inside the disposable, and it's completely isolated from contact with the patient. So the camera doesn't need to be re-sterilized, etc. It's kept completely clean. It can obviously be wiped down if you're getting secretions and so forth on it. And then you'll see that the camera head shows me a red light which says, okay, we're booting up, we're ready to go. And when I switch it on, I get a view through the device and I can see what's happening in the bowl of the device just underneath this little laryngoscopic blade. So there, in the bowl, if I bend it down a bit, you can see the end of the camera coming out in its little enclosure, as well as the light source and the drainage tube there for my supraglottic drainage. And there on the tip of the device is the drainage for the nasogastric tube to go through. Right, so this is now prepped and ready to use. The manner of using this is quite simple. Make sure my patient is either completely obtunded or anesthetized, and I put it in just like any other supraglottic airway. Now you'll see, it is quite long and it is quite bulky. What you need to resist is the urge to hold it up here, because sometimes you can then disconnect the camera and it takes a couple of seconds to reconnect. So hold it nice and low down, like you would hold a laryngoscope. Remember, this is kind of a hybrid between a supraglottic and a laryngoscope. Right, then I'm going to pretend I'm touching the stem to the chest. I'm going to put it into the patient's mouth. I'm going to advance it in like I would any other LMA. And when it's in, and I'm happy with how it's seated, I blow up my laryngeal mask cuff. Whoop, And now I can connect whatever ventilation I'm using, let's say it's my ambi bag, and I can start to bag the patient. It's not disconnected. Then to tracheal tube connector there. Right, I can start to bag my patient. And you can see that you can place this swiftly and easily like you normally would. Now, on the video screen, I can actually see and manipulate the device while I'm busy ventilating. In the operating theatre, or where I've got a ventilator pre-hospital, I actually connect the ventilator at this stage and let it ventilate all of its own accord, or I could be having someone else or an assistant doing it. Now on the screen, I'm able to manipulate the device, lift like I would for a laryngoscope, and obtain my ideal laryngoscopic view through the device. So what I'm seeing here nicely now, vocal cords, arytenoids, etc. Then, when I'm ready to intubate and my position is optimal, I can say to my assistant, could you please deflate the cuff, or I can alternatively do it myself. So, in between breaths on the ventilator gives a breath, as soon as it's finished, I deflate the cuff, I advance my tracheal tube goes in, re-inflate the cuff, and now I can carry on ventilating. I think I've picked a tube with a weak connector here. Alright, and now I'm ventilating with the endotracheal tube in place. If I were to struggle, let's just rewind this a moment. And let's say that I was really struggling to get a good view with my on my monitor screen. What I can now do is I can bring this angle connector into play. So let's just presume I've had this connected and ventilating away. I can pop open the elbow connector, and I can now pass my bougie down through here. And on the other end, when it pops out, I now have a completely steerable little tip with a cadet tip that I can get in around a tricky corner, and once again then deflate cuff, advance tube, and remove the bougie, re-inflate the cuff, and keep ventilating all the way through. In the situation where even that is tricky, I can always put a flexible fibroscope or a bronchoscope down here, and I can do a video-assisted fiber optic intubation through a supraglottic airway. That's a lot of tech. Okay, so you said to me, well, no, fine. Now your patient's intubated, they're connected to the ventilator, they're being ventilated. I'll leave that out the way for the meantime. But this looks really bulky and inconvenient. Well, it all comes apart. So, camera head comes off once I'm happy with the positioning. This rigid introducer peels off like this, and following the curvature of the airway, I can take it out. And now I'm just left with a soft LMA stem and the endotracheal tube in place. If I wanted to, I could cut off this battery pack and dispose of it. If I really want to, I can take out the whole supraglottic airway portion. So I disconnect my endotracheal tube connector. I make sure that my LMA cuff is deflated, and you'll see that this has got a channel on the side here, so I can hold the tube in place, get a hold of it over there, or I can get rid of the supraglottic airway completely, put my patient back on the ventilator, and we're good to go. Right, so a very interesting device. It allows you to secure the airway with a supraglottic airway, position it optimally under vision, intubate with a minimal, next to no interruption in your ventilation and your oxygenation, and then you can remove the whole spiel quite quickly and easily. So, very interesting device. In our hands, we found that we have a 98% success rate in placing the device on our first attempt, and we had overall a 95% success rate in intubating with the device, and that was quite a strict protocol as well. So I suspect ultimately the success rate will be as good, if not better. So, TotalTrack VLM hybrid video laryngeal mask, which allows you to intubate through a supraglottic under direct video vision.